Good morning, afternoon, or evening, wherever you happen to be. It's nice to see everybody on this Works in Progress. Most of you probably do know me, but I'll just introduce myself anyway. I'm Catherine deVries. I am a faculty member at the Center for Global Surgery. I'm a pediatric urologist, and I have been working in pediatric urology and global surgery for about 30 years or so. And in addition to pediatric urology, I have focused on general and adult urology, as well as global surgery and systems strengthening through many organizations. But what we're going to talk about today is specifically pediatric urology and the program that we're working with between the University of Utah and the West African College of Surgeons, as well as the College of Surgeons of East, Central, and Southern Africa, which represents most of sub-Saharan Africa, except for South Africa. And I'll talk a little bit about how that collaboration works and why we are focusing on that area. So I will just share my screen here and talk a little bit about how this evolved. So a couple of years ago, I was asked by the Journal of Pediatric Urology and the British Association of Pediatric Urology to consider how we might look at the future of pediatric urology, and that was actually sort of an intimidating topic. What's the future of any particular field? But as I started to think about it, I started to think about, well, what are the needs? Where are the kids? Where are the specialists? And that brought to mind, a lot of need for some new information and review of history of the whole field. So Hafsa, Zahid, and I will go through this. Hafsa is a staff member here at the Center for Global Surgery and has helped me with some of the research with the Societies for Pediatric Urology. So this is where we started with the, quote, future of pediatric urology. But for those of you who are not urologists, it's helpful to think about what exactly is pediatric urology. Well, urology in general is that field of surgery that includes the kidneys, ureters, bladder, and genitalia. So many functions of those areas. And we intersect with many other aspects of healthcare, including anesthesia. Pediatric urology in particular overlaps with pediatric surgery in our need for specialized anesthesia. When you think about kids age, 6 months old, the anesthesia is going to be completely different from, a 250-pound adult man. And so everything about it, from the technique to the equipment, has got to be specific for pediatric. Similarly, for radiology, pathology, nursing, the facilities, and even the training and academics. These are areas that are needed specifically for pediatric surgery and pediatric urology. So we have this kind of a hybrid field. But we got our start, honestly, with plastic surgery, and I'll talk a little bit about that. So the most common visible abnormality is hypospadias. That is actually 5 times more common than cleft lip and palate. And the other common visible abnormality is neural tube defects. And here are some pictures of what that looks like in children who are born with spina bifida. They get hydrocephalus and a spinal cord neural tube defect, but it also affects their bowel and bladder function, which is a huge problem all over the world, including the United States. But hypospadias, if you don't know what it already is a defect of male genitalia where the hole where a boy or man would urinate through is not in the right location at the tip of the penis. It's somewhere down the shaft. And this is a very, very common abnormality. 1 in every 250 boys is born with this. So why have you never heard about this before? Well, most people are not really sharing that information. It's not visible to your common person, and but it very much affects people's quality of life in every aspect of their living from childhood on to adulthood. And then the other problem areas include cancer, exstrophy, and transitional care, which is transition from childhood into and through adulthood. So the challenges in low-income countries are the same pretty much everywhere. And they include geographic distance, travel, visa, and COVID have made all of that even more starkly clear. And we have had, until very recently, unstable but improving communication. Now we've got WhatsApp, we've got Zoom, we can talk to people in different time zones in different countries and continents. So that problem is being solved. But we still have problems with unstable and inconsistent electricity. So everything that happens in a hospital requires that, including the lighting and refrigeration and everything else, supply chain, and then patchy education. I like to think of some of these things through Paul Farmer's 5 S's, and because I can think of those 5 S's and identify some of the needs. So the staff, stuff, space, systems, and support mean that you need to have staff that knows something about pediatrics. In a general hospital, that's not always true. Nurses trained to take care of kids with catheters is a specific area of training that's not, you cannot take it for granted. Nurses need to be trained in addition to the surgeons. So do the anesthesiologists. And it's not generally known how to do spinal or epidural anesthesia, especially for kids. Many places, kids get either just general anesthesia or even sedation. Pain management on the wards is rarely found, but is very helpful when you're doing pelvic surgery. So these kinds of things are important aspects of building pediatric urological capacity. Also, ultrasound, CT, and fluoroscopy. You think about the stone burden. Stone burden is not just in the stone belts as we used to think about it, arid places and hot places. We now find that in the United States, stones in kids are very, very common. And I think we can attribute a lot of that to the Western diet. So, but as people around the world are eating more of that, we are seeing more stones, and you do need good radiology to identify them in order to manage them. And then pathology is a problem pretty much everywhere. And we are now starting to identify ways to address that. So getting back to Paul Farmer's S's, the right stuff. Urology relies very heavily on scopes, cystoscopes, resectoscopes, laparoscopes, nephroscopes, ureteroscopes. All those kinds of scopes are part of the usual toolkit in a high-income country. In almost all of Africa and many parts of Asia, people may have only one kind of scope, like a cystoscope, and maybe not the right size, because if you think about it, a cystoscope that will fit a 6-month-old or a neonatal baby is not the same as for an adult man who has a prostate issue. So getting these scopes, maintaining the scopes requires, a relationship with the manufacturers of the scopes and the retailers. So these things are not trivial problems in the hospital system, and it's not necessarily sufficient to just donate them. They still need to be maintained and replaced from time to time. Additionally, we have the problem of the consumables, the suture, catheter, and dressings, which are unique to pediatric urology. People will adapt where they can, and so you might use a cystoscope to do laparoscopy if that's all you had. But we find ourselves sometimes dumping technology in places where it can't be used, in places where it will just sit unused because it can't be sustained. The parts are not available, the technology is old, and therefore it's ethically questionable whether we in high-income countries should carry these things along in our suitcases or send them off on in big containers to be managed as waste in some other place. Inventory is a chronic problem. You can do ad hoc inventory on a 1-week trip, but long-term, knowing what you have on hand and replacing it as necessary is a hospital systems problem, but we run into it often in places where new surgical techniques are being introduced. There is, in terms of space, a really nice initiative for children called Kids OR. This is a nonprofit that's based in Scotland and has been building children's operating theaters in general hospitals and sometimes standalone in many different places, mostly Africa, but also other places. So this is a very good collaborating organization as children's surgery is starting to be built up. I mentioned supply chain. The problems are many, including road conditions and weather conditions. But all of these systems are common for all global surgical needs. One of the things we do a lot here in the Center for Global Surgery is advocacy, local, national, and international. And we look for financing both through big initiatives and philanthropy, and then national health priorities. This is all common stuff to global surgery and familiar to all of you. When we think about pediatric urology, we need to then start engaging with the colleges of surgery and the societies, for the reason that these are the certifying groups. So, for example, the West African College of Surgeons is the entity which confers fellowship status on candidates who have trained in the West African region and people practicing in that area. Similarly, the College of Surgeons of East, Central, and Southern Africa does the same. The Societies for Pediatric Urology is a group of societies based in North America and is inclusive of the SPU itself and the AAPU and a bunch of other pediatric urology subgroups all together. I happen to be the chair of the global committee, the task force, which engages with all these others. But the British Association for Pediatric Urology and the Pan-African Pediatric Surgical Association. These are just some other groups, including the Global Initiative for Children's Surgery, that all can work together, should work together, don't always talk to each other. But if we're aware of them and if we can network, we can build on the capabilities of all of these groups. In addition to that, there are, as you know, a lot of NGOs and academics that are working in different ways to build capacity. Some of those involve trainees, like Incision. Some of them are based in different countries, like Kind Cuts for Kids is an Australian NGO. And some of them are more academics, like AAGS and the CUGH. So these are all different facets of the group that can be brought to bear. But I think we do have a growing divide in terms of our skill sets and our capacity. So in the high-income countries, we have robots. We have specialized scopes, as I mentioned before, CT, MR, and all these other things that are standard of care. In fact, a lot of our trainees have trained on robots and don't even know how to do open surgery anymore because, you know, nobody does it. But in low-income countries, robots are not generally available, not even laparoscopy, not even cystoscopy, let alone all of these other oscopies. And as I mentioned before, the variable radiology, basic labs even, can be hard to get. So we're going to talk more about the gaps in education, because I think that is that's really one of the most approachable things. I'll just mention here at the bottom right, this picture of GASHU. It says GASHU 2017. That's Haiti, where we were teaching laparoscopy. That operating room has completely been dismantled recently by the gangs. So even our best efforts sometimes fall apart because of local conflict. In East Africa, Phyllis Kiza, who is a pediatric surgeon in Uganda, did a survey looking at the unmet pediatric urological needs in LMICs, but focusing mostly in Africa. And they found what we have previously discussed, that the needs are greatest for hypospadias and for the other listed problems. Interestingly, there are a lot of other pediatric urological problems that, if they had the ultrasound and the radiology and the prenatal ability to identify them, would probably be seen as also unmet needs. But because of the limitations of diagnosis, they're not even known. They don't even come for care. The Global Initiative for Children's Surgery is one of these groups that is starting to work. So where are the kids? This is an interesting graph to me. This is from the World Bank, and it's looking at the population of kids age 0 to 14. And in 1960, there were about 38% of the world's population was 0 to 14. That has now dropped to under 25%. So the world is aging mostly. They're getting to be my age. And very few kids age 0 to 14, relatively speaking, in North America, Europe, and other places. The place where the birth rate remains high is Africa. and some parts of Asia and a few places in Latin America. But the net reproduction rate has already fallen below replacement in many, many countries. And it did that before the year 2000 in the darkest purple ones. But in places that you see the deep red and orange, those are projected to continue to grow through the 2000s. So that's really where the pediatric needs are. They are in Africa and a few places in South Asia and the islands. So a lot of places have already met and are falling below the net reproduction. And if you want to think about why there is migration, as there is, it is because these places not just have growing populations, but also are lacking capacity. Looked at a different way, the worldwide total fertility rate in terms of live births is really in Africa. And those few countries we were talking about in Asia and Eastern Europe. We mentioned a few minutes ago about spinal cord and neural tube defects, excuse me. A lot of these can be attributed to a lack of folic acid. And we have public health standards for folic acid fortification in many, many countries of the world, but not in others. And in those places, the neural tube defects and the consequent urological and orthopedic problems in kids are going to continue to be a problem. This is an area for advocacy, not just neurosurgery, but urology, orthopedics, and a cross-section for surgical care. Looking at the American Urological Census from 2020 and 2017, we can see that over the last many years, we have trained an awful lot of pediatric urologists. They are now over 1,000. We're into 2024, well over 1,000 pediatric urologists for a dwindling population of kids in our own country. So we have more practitioners and fewer kids, whereas in Africa, there are a lot more kids and a lot fewer physicians. So, you can argue that that's where the need is. So now that I've convinced you of that, the global task force that I talked about before undertook a survey. We did this about a year and a half ago. The first survey was just to find out who in the societies for pediatric urology and the wider network was interested in participating in global work. And this was sort of a quick and dirty Google survey. Well, it overwhelmed us. We had about 120 responses, and it produced an Excel spreadsheet, which was totally unmanageable. And we could not really sort through all of the responses to identify not just who the participants were, but where they worked in terms of their primary institution. I'm talking about universities in the global north, and where they worked or would like to work in the global south. So we had a lot of information, but no way to really sort through it and work with it. So we developed a red cap based at the University of Utah, but we also developed a website which is housed at on the Societies for Pediatric Urology, an ethics statement, and other ways of communicating with a task force, much of which has been housed here at the University of Utah. And we are now developing formal collaborations with the Cosexa, and wax in sub-Saharan Africa. So we're going to talk a little bit more about this REDCap database and what it has enabled us to do. And we've done that with the support and assistance of the CTIS here at the university, which has a deep experience in developing very sophisticated REDCap, way more sophisticated than I could personally do. But Mary Arian there has been very, very helpful in developing that with Hafsa and me. And we have then developed, we have subdivided this data into instruments for reports and review. And we can then pull from that the member demographics, institutional data, experience and interest, and all that sort of thing. And so now I'm going to turn this over to Hafsa to talk a little bit about how this REDCap looks and what it's useful for. So Hafsa?
Thank you, Catherine. Hi, guys. I'm going to keep my camera off because of the place where I am, internet is not stable. So I just want to make sure you guys can hear me correctly.
Yeah, Hafsa's in Pakistan at the moment, just so you know.
So thanks, Catherine, for explaining the need for the project and about the background. And as she mentioned, we created this REDCap project with the help of Mary Arian. She was a great assistant in creating this whole project. And this project is divided into 3 subsections, or we call them instruments. The one on the screen, it's called the participant project. That is going to be the basic, like main instrument. And then the other 2 instruments beside this one are the work location project, and then the sponsoring organization project. This participant project is divided into sections, which I will talk about later. Next slide, please, Catherine. So this is the work location project that basically goes over the demographic of where the participants are working, and if their work location offers any kind of training or observership. Next slide, please. And this is the last one, sponsoring organization project. And this basically goes over the geographic location of the organization, of what kind of organization it is, and the areas that they serve if they do. So now I'm going to talk about the participant project. That is going to be the basic one, and that feeds into the work location and the sponsoring organization project. Like I mentioned, it is subdivided into sections. And the questions in these are from the original Google survey, but we added additional questions to get the better picture of some of the things like the volunteer interest of the participants, and then institution interest in observerships and fellowships too. So in this project, we collected demographic information about the participants, and if their place of work has any training program, observership, or fellowship to support the pediatric urologists in LMICs. Next slide, please. And then we also collected information about their participants' prior involvement and about their engagement interest. So all these questions talk about those information. And some of these questions had branching logic in them just to give it a neat look. So based on their certain responses, it would open up to a few more questions for us. Next slide, please. And this is just like the example of the engagement interest and all the questions we asked in their the participants about if they're interested in any kind of subcommittees or where they would like to go if they're interested. Next slide. So based on their responses, Mary created the dashboard that is available on the SPU Global website. this is a live dashboard, means if more people are interested and they take the survey, based on their responses, the information on these dashboards will change. So you can see on the right side, it talks about the subspecialty, like surgical specialty, the participants are involved in. And left side talks about the job titles they are in. And the bottom one is places of employment, within US and outside US too. Next slide, please. This is another dashboard that that was also created based on the responses, that talks about the subcommittee interest and mission history and number of prior trips these participants have taken. So we can see all those things in those dashboards. And we also, next slide, please. And this slide basically is just showing you the reports we can also create based on the participant responses. This is just a few of the reports we have. There are a few more that I did not include, but these include all the about the demographics, interest in their subcommittees, and if the institution offer any kind of observation and training program. So we can create separate reports based on those questions. So this is all the information that is available through REDCap. Next slide. So, Catherine.
Yeah. So, this gives us such a wonderful tool for being able to pull out, if we wanted to look and see who has volunteered or worked in Ghana, we could do that. And not only that, but we could find out where in Ghana people have worked, or in Mongolia, or any other country, because one of the questions asks in the branching logic where people have previously worked and have connections. And so we can look all over the world, and we can also, and we've asked the people also to list on Intersurgeon, which is one of these NGOs, where they will where they're interested in continuing to work. So we're working in a collaborative sense through many different areas, academics, NGOs, colleges, and individual sites to support training for these places. So we do have a couple of new collaborations, though, and this has just come about in the last several months. I would say they've been brewing for possibly 15 or 20 years, but now they have developed a certain maturity that they are now thinking they can start developing their own training programs with support through SPU and through some of these other networks. And this I find to be most exciting because they already have their own plans. The first one is through the West African College of Surgeons. That will be the certifying body and will confer a certificate of advanced training for pediatric urology. It is envisioned to bring in people from the fields of urology and from pediatric surgery to train in a common program to support for the urologists who mostly train in adult urology to be more effective pediatric surgeons, and for the pediatric surgeons to become familiar with all of these scopes and all of the endoscopic work that urology does. And so this is envisioned to be starting off in 2 Anglophone and 1 Francophone country. They're at this time reviewing the training sites, and they are hoping to start in 2025. Their proposal includes observerships in the States, Canada, and Europe. visiting surgeons from the high-income countries, and I would say also inclusive of South and Latin America. There are visiting surgeons who do go to Africa from, for example, Chile. And so I don't want to neglect to include them because they are part of this, as well as there are Asian anesthesiologists that we know who also travel to Africa. And there are virtual case conferences that we are able to do from the comfort of our own living room when you consider the time differences. The more recent development is in the Cosexa region at Kilimanjaro Christian Medical Center, which has a long-standing program for training urologists. They have actually an institute for urology that's been in place for many, many years. And this is the proposal that Dr. Orgenis has put together. He sent me this a week or two ago, but they are going great guns in pulling together their training program. So they already have an institute, they already have dedicated theaters, they already have a lot of things going, but they have not really pulled together their accreditation for this particular program. So we will help support that for them. And this is their vision for it. I had a Zoom with them on Sunday morning. So they're moving forward with this. So that's what we wanted to share with you. And I'd like to now open it for questions, comments.